It's nice to see you again after a weekend of thinking and writing, and now we get to reconvene. And what's happened to me in the last 2-3 days is that I have read the phrase abundance of caution more often this weekend than I have ever seen it ever in my life. People are doing crazy things. The most recent article that I read was you must quarantine your pet because a 17-year-old Pomeranian in Hong Kong has tested weak positive for coronavirus, and out of an abundance of caution, the pets now must be quarantined. This phrase, abundance of caution, has come to mean for me that people have lost their decision-making capacity. And it makes sense when you consider the uncertainty that we are steeped in at this moment. We have no visibility of the future. The mathematical models of exponential growth are highly sensitive to the parameters that we set at the present time. And a little bit of a change here, and these are very uncertain parameters, creates an enormous change in 7 days or 10 days or 3 weeks. How should we steer through our response to this fog?
Well, you hit the key thing here is we are in the middle of an anomalous situation that's come upon us. And you're highlighting some of the classic things we find about what makes even recognizing it's an anomaly, much less starting to figure out what are the explanations that would account for this. And even what are the findings to be explained keep changing. Or we have uncertainty about the numbers about what we're trying to explain. And how do we put actions into effect when we can't wait for a full diagnosis? Because if we wait till we completely understand, we know we will act too late and in ways that will be ineffective relative to the growing crisis of care in our particular case that can and has developed. So I think our new line of steering through fog captures what's going on. And we have it where we really have a multi-car that are interlinked together that have to steer through this fog, because decisions at one level in one part of the world change the kind of fog, change the kinds of obstacles we might run into in that fog, change where we might find ways to break out of the fog with some definitive, decisive, constructive actions to make things work.
But David, it seems to me, hold on just a second. It seems that really what we're doing is we're racing through fog. Because it's not like we can just creep at a very slow rate, kind of feeling out in front of us, right? We know that the rapidity of the response makes a difference. We know that action early makes a difference. And so I think that steering, for me, suggests kind of like being in a boat in the water, and maybe we're carefully navigating our way around the shoals. It feels to me like we're having to move much faster than that, right? We're in a car and we're on the road and we got to get somewhere fast.
Well, what's interesting in tempo of operations and how that applies to this situation is that keeping pace is knowing when to move quickly and when to slow down. When it's important to wait for the key information and then act decisively versus when is it okay to rush ahead. So what do we know? One thing we know is the journeymen rush ahead too quickly and don't know how to measure their speed relative to the availability of information. Well, we know that there's difficulties in being decisive, and that decisiveness is an essential property. And so the question is, but under uncertainty, decisiveness can lead to things that we'd later turn out to be poor directions to move in. We have partial information about the state of the world, partial information about what we can do constructively or what we can do to protect ourselves. There is the individual's decisions do not occur in isolation of impact on others, right? As they change transmission, an increasing transmission rate increases risk to other groups. So even people who are at very low risk of serious disease or and consequences need to change behavior because they have loved ones who are at risk because of comorbidities or age-related, and protecting them becomes important.
This is coming up now in the public discourse. There's a disagreement in the White House on drug treatments for COVID infections. It sent you a study, and it was a small sample of patients who responded well to, might be pronouncing it wrong, hydroxychloroquine and erythromycin in combination. Right now, there's a lot on social media about the promise of that anti-malarial drug to shorten the duration for which people are suffering under respiratory duress from COVID. But there's disagreement in the medical community about whether that's a good option. Why?
Well, the big picture, I mean, when you pose it that way, the simple thing is, wait a minute, there's a bunch of things that you have to check, right? You have to check on, well, who does this actually help? Because we have different kinds of populations, age, comorbidities. Each of those drugs has contraindications when you shouldn't use them. In combination, they have more contraindications. Who were the patients like and what diseases did they have? Were the studies done on these from which we understand some of the limits and benefits of these drugs? None of them were related to the kinds of situation we're in. So this illustrates actually a very general dilemma that arises in these kinds of crisis situations. And that is, it's a variation on what's called the speed thoroughness trade-off. Right? Because of things developing with high consequence or high potential bad consequence, we want to do something quick. And this is where people in crisis have to be highly responsive. You can be highly responsive because you build a readiness to respond, as I just talked about. Building that readiness to respond, I can be very responsive when I see needs arise. And intervene in effective ways, such as giving treatment that speeds up the course of recovery or increases the probability of recovery. On the other hand, in these situations, we also find that one of the common failure modes, patterns that we see over and over again, is missing side effects of a decision or change. So you see something and you head off, but you don't analyze the other effects that go on. And it turns out one of those ends up producing bad results or creating more problems or making the situation worse. So we've seen that over and over again. This is true of complex systems where any given action has multiple effects. And medications are an example of that. They don't just have one effect. They always have multiple effects. And in fact, we call their primary effect, it's our intended effect, and it's an efficacious or desirable effect. And so they have therapeutic range. What dosage actually produces effects? Now we're seeing initial reports of overdoses of these medications in these patients because we don't know what the therapeutic range is. We don't know what kinds of dosage works. What's too little to have a therapeutic effect? What's a dose that has these other negative effects? We also know they have some heart effects, and we're seeing signs that there are some puzzling but multiple reports from China, Seattle, and Italy of a sudden cardiac death of patients who seem to have turned the corner on their respiratory distress syndrome. And people are not sure of the physiological mechanisms that creates the secondary risk or how prevalent it is or whatever, right? Back to the steering through fog, racing through fog, we have new information about new threats arising. So the issue is, how do you balance this trade-off? I need to be highly responsive, but I still have to do some of my thoroughness checks. What really goes on? Who really benefits? What else is happening? What about shortages? If we deploy all this medication, what about the people who use this medication for other conditions?
One of the important things about racing through the fog is to avoid making irrevocable commitments. I'm thinking about the Titanic. It's a very difficult ship to steer. And when you're going fast, you've made a commitment to a direction because you can't change the direction. When we're racing through the fog, are there commitments we make that are either revocable or do not compromise our optionality, our adaptability, so that as we learn more, we could roll them back or reallocate or change those commitments?
That's an excellent point, and something that we see all the time with experts in these situations, right? They behave very differently when they get to a point where, and they stop and look like they're making a choice when it's, once I move on, it's irreversible. And I could tell you story after story, but I will resist my tendency to do that. We see them constantly creating hedges to create the possibility for future action. And we've seen this actually a lot in our studies of emergency medicine, trying to understand how they generate resilient performance when they get particularly challenging cases, or a set of particularly challenging cases that creates overload for emergency room. And we see them often, especially the most senior people, focus on how to create and continue to create options for care should more problems arise, should what they thought was going on turn out to be something different. What they thought was effective turn out to be ineffective, or worse, what they thought to be effective give them information that in fact something else more that quite threatening and dangerous to the patient is going on. So this is very common in understanding expertise in the emergency room.
I've come to realize that predictions are antithetical to maintaining optionality. Once we make a prediction, it is human nature to become vested in being right or wrong. It introduces this confirmation bias. We filter our observations about the world through the lens of our prediction. I now instruct my team that they're prohibited from making predictions so that they don't become ego invested in a vision of the world that would make them right or wrong. Instead, we offer anticipations. We say, well, here's a possibility. Here's another possibility. We've changed the language that we use so that we don't become committed to any single vision of the future.
So
in this crisis, I'm seeing predictions all over the place.
And well, that's a very important point. The studies again show that this openness or tentativeness, right? And we're gonna notice something, connect to what I said earlier that people may remember and think of as opposite. We're going to connect it back together, because part of the expertise here is things that look incommensurate turn out to be important to combine in these kinds of crisis situations. So what we find over and over again is the people who are really good expert at this are sensitive to the future without overcommitting to one vision of the future. So they don't say it's going to work this way. They let the world tell them. But they're highly sensitive, and they look for the cues that will tell them, are we going this way or this way? So they can act early. So what we see is a paper from Gary Klein and I about 15 years ago summarizes some of this stuff over a wide range of settings where we look at these kinds of experts. And what they do is they pick up early signs, right? They recognize this may change the course of actions or change what they need to diagnose and understand about the world. And they change their effort to monitor and pick up information. They change the way they interact with others to pick up information. Are you seeing something? Have you heard about this? Have you seen anything like this? They act suspicious and they change. Now, if they alert their colleagues and say, given what I'm seeing, I think we should change course, there's not enough evidence for everybody to change course given other factors that came into why they set the course they were on, which has a history and an analysis base and trade-offs and whatever behind it. But they're highly sensitive to this, and then they get more evidence which allows them to be faster at changing course than other people who go along, and then when the evidence is definitive, you need to be on another course, harm has already built up or the risk of harm has increased dramatically. And our paper on this, and this is part of the reframing process. So think of experts as being poised to reframe. They're not stuck in one way of looking at the world, but they're ready to reframe. And for our AI friends and automation friends, this is one of the things. People can reframe. People are the only computational agent that can reframe. It's hard for people to reframe. You talked about how we fail to reframe. Machines don't reframe. Nobody's tried to build a machine that could reframe. Nobody can even think about what would it mean for a machine to reframe. But this is one of the special capabilities of people that become particularly important in this. And we see a bunch of evidence. You've asked me about what's novel. So speaking to someone who's about to go into ICU, preparing for a potential surge of COVID patients, they've got just a couple so far. One of the interesting things is from the disease point of view, they approach it from the framing that everything is novel. Doesn't mean everything is really novel, because much of their repertoire is their repertoire. They have this technique, this variation, that variation, this specialty, this sensor, this signal, right? They're models of the physiology, but they approach this as everything is new, that they're ready to change. They are already evaluating what's the best way to do things. They're trying to decide, make trade-off decisions in advance. They're trying to act early in order to be prepared if a patient has a physiological crisis and their parameters go downhill rapidly in respiration or heart, and so they can respond quickly and effectively. And the last line in our conversation was, and we know all of these changes we've already made, we're going to have to be watching for the signals and be ready to change again. That we have to be ready to do that. And a lot of that is how they share information. And this is where we see the horizontal, informal, emergent lines of communication between people who do similar jobs at the front ends, intensive care people talking to intensive care people, cohorts of people who are residents together or fellows together are now and have spread out around the country or the world are activating that informal network. What are you seeing? What was hard? We're getting ready this way. How did you get ready? I do want to mention New York statistics because we talk about when can we see things. But New York has gone from March 15th with 3 deaths, 5,000 known cases, not reporting hospitalizations, to yesterday with 114 deaths, about 2,000, almost 2,000 in the hospital. It doesn't say how many are in ICUs.
That's 114 is the total death toll, not the daily death toll. Is that correct?
That's the cumulative death toll. Yeah, this is the covidtracking.com. There's one of several. I didn't pull them all up in advance here. There's one of several we're monitoring. And for our information, there's a GitHub repository as well. John Hopkins has a repository. Yep. They don't always agree. They're not always timely. Yep. But I would say that that's also back to our cooperation point that you really pushed us with, which is we're operating on a rule of 2 or 3. Find more than 2 sources to check, cross-check. If you can't, at least get 2 before you dig into anything. So the exact numbers don't matter in that. The issue is here we're seeing the explosive growth and challenge to both the supplies and to the ICU load, even though they don't give ICU.
We don't have good data on the ICU, which is frustrating because that's a leading indicator of deaths. And without those leading indicators, total cases is not a leading indicator because it's unreliable. But hospitalizations, and in particular ICU data, would be a leading indicator of what to expect from the disease. Are we still in the exponential growth phase, or are we seeing that growth peak?
Well, right now, there is some debate in Germany about what's going on there. And again, I think it's a nice illustration. These gross numbers are not helpful. They're not diagnostic. They don't help you understand and therefore select among actions or how do other parties should value different actions and their disruptive factor that they bring along with them. Germany has a relatively high number of cases, reasonably high hospitalizations, very low death rate, under 1%. They are doing more extensive testing. Remember, some of the people are saying, and I don't know, Dave, if you or Tom have an opinion, but that for areas doing limited testing and targeting the limited tests available to very specific circumstances that the testing data, the total case data is particularly misleading because it's biased so much by the limited testing and the bias testing. In fact, hospital admissions and ICU admissions would be much better data on which to base what's going on and project trends. If you think about that, it's interesting that this particular database didn't receive any hospitalization data till they were up to 44 deaths and over 1,500 hospitalizations. Yep. Remember, when we say New York, we're at this stage, that's largely New York City and surrounding area.
So Dave, do you know, just a quick question. I mean, it seems, so one of the challenges that we have here, and this comes up in all different kinds of systems, infrastructures, whatnot, is that the jurisdictional boundaries on which decisions are made and or data is recorded don't necessarily align with the system and the dynamics that we really want to track, right? So it seems to me, do you know of anybody who, or any organization who is tracking this data, let's say by metropolitan region? Because to the extent that, you know, if this is a rolling dynamic, a rolling outbreak that is where we're mostly focused on the large population centers, right? I mean, to the extent that there is previously some real mixing of a population that was going on, we might think about major metropolitan areas. It'd be interesting to look at this from that perspective as opposed to the aggregated state level, right? So you just said that, you know, the data for New York State is largely centered on New York City, but in fact, you know, what we're seeing reported for every state is sort of this weird amalgamation of what's happening in the cities as well as what may be happening in other isolated populations. And what we'd really like to track is something that maybe more closely mirrors the interaction of the population.
Absolutely. I think that's, this is, I think, one of the interesting aspects of this for all of us who have a stake in this crisis, which is all of us, which is we don't have good information that discriminates between trajectories and key issues. And that we find that people like us aren't helping the larger, wider body when we're not on the front lines of generating care or resources for care or making key public policy decisions, is how do we understand the options? How do we understand the severity? How do we understand the potential for getting slammed with overload? How do we understand the potential for excessive deaths? That someday we're going to turn around and we're going to be able to calculate, right? And that right now I'm operating on the early data that suggests that the places that do well versus the places that get slammed and have to be very reactive, right? We are estimating an order of magnitude difference in deaths. It may be lower, may be higher for some places, but the difference right now, right? If you want to say to people this matters, or why this matters, is that you need, doing well, cutting the transmission rate and taking care of the people who get critically ill could have as big as a 10-fold difference in the ultimate mortality of this virus.
And it could have as small a difference as?
I don't know. I haven't tried that.
The kind of language that we use, as big as 10-fold, creates a distortion in our mind of what the uncertainty is, because we put a ceiling on it when we use the language as big as, without saying and as small as. And the fact is, we don't know what the bottom is because we don't know what the efficacy of these social isolation, social distancing, shut down on the bars type policies are.
Right. But look at us. Remember, we're actors like these, right? People handling the kinds of crises we've studied before, only this is at a bigger scale. So what did we just talk about? They're looking for these early signals. If you look at the difference between Italy, Wuhan are slammed, much higher fatalities. We've seen places get their outbreak, Taiwan, Singapore, right? What have they done? They've kept fatalities below 1%, or maybe lower. They've done they've done some things differently with extensive testing. They're smaller jurisdictions, back to Dave's point. Taiwan could have gotten, a large influx given their relationships with mainland and stuff. They've done some things. And when you make estimates based on early estimates of fatality rates, so we're using uncertain information, but it gives us a way to lean one way or another as we evaluate these courses of actions and when to take decisive courses of action.
We also might look at Australia with, 1 million ethnic Chinese, very close trade ties to China, 100,000 Chinese students in Australian universities. And they haven't done the same kinds of things that Taiwan and Singapore have done. And they have largely been spared the kind of outbreak or the exponential increased numbers that we're experiencing in the United States.
Is it coming? Right. I think if you want to, there's a way in which you pose these as this kind of limited experiment we're doing in real time, where I've got to make something and I need cues that help me discriminate between trajectories and possibilities. And I need to actively search out that information. And it's this active seeking out rather than waiting for stuff to bubble up.
Right.
And they're looking for what's going to be diagnostic cues. There's a long history of this in some of the cognitive psychology areas that go back quite a ways. What are the key diagnostic cues? How do I search for them and identify them? I can't wait for perfect information because I got to do something. Yep. I got to go left or right. I got to do more of this or less of that. Right. And so I need diagnostic cues. Remember, we can guarantee, when people spend years and millions of dollars and hours figuring out, they'll be able to tell you exactly what were all the right decisions and all the all the jurisdictions after the fact. We will be wrong, right? And we will be over-prepared in some places. But we already know we were under-prepared in places. And we already know that made a difference in mortality. So
let's bring up a few things that are a few things that either could be done or are taking place that maintain optionality and flexibility. And we're not going to talk about their cost, but these are decisions that would improve response without impairing the response flexibility. More personal protective equipment for the medical workers. It in no way constrains your future decision-making to have masks and ventilators on hand or shields or whatever it is that the hospitals need. Expanding the healthcare capacity to intake, to triage, and to treat people. Again, a lot of flexibility to create triage tents in the parking lots, to expand the ICU, and it does not invoke irrevocable costs. So these are two examples that come to mind. Increased testing to get better data and track. There's economic costs, but it does nothing to impinge upon our future flexibility of options. But the big debate right now is about quarantine, isolation, shelter-in-place orders that put people out of work, that shut down sectors of the economy and have longer lasting, more difficult to reverse effects. At what point do we decide we've got information that would roll back experiments that are not working? That is to say, at what point do we decide whether the experiment is working and worthwhile? Worthwhile in the sense that it constrains our future options.
So I'll just add to the beginning of what you ran through on some of these things, that they are highly directed at hard constraints that have to be dealt with.
Yeah.
Or we're failing to deal with hard constraints that exacerbate the situation. You're seeing this in shortage of medical personnel combined with shortage of protective gear. So you get more healthcare workers exposed, but you run out of healthcare workers. And so you're already starting to see evidence of I'm not just relying on news reports, but talking to people more directly involved, that mere exposure or some kinds of mere exposure to potentially being infected is not enough because you just run out of people to take care of people. And so things that weaken your workforce for handling sick patients are tremendously constraining. And anything you can do to delay, reduce that effect, that attrition effect, which is one of the things we're really trying to focus on. We have a lot, I think we could still say in this crisis about how to manage attrition effects. But these interactions are hard constraints that really make a difference in the frontline and near frontline capabilities for fighting this at whatever scale and extent this has to go on. The one about economic interventions, you've heard me say my basic one: until and unless you reduce transmission below 1, this outbreak doesn't end. And I don't care what jurisdiction, whatever. The outbreak keeps going. The number of really sick people will go up. I don't know what.
That's a circular argument. The one is based upon the fact that the outbreak is still going on or is still increasing. That is, you're focusing on the speedometer, not on the accelerator. You can watch the speedometer and say, well, until the velocity crosses a third, but that's not the lever of control. R is a description of whether your control is doing well or not. What are the underlying mechanisms that get it under control? And here we can have a debate about whether social distancing is effective or whether we just need to wait for the days to get longer.
So the second part, right, that you're getting at is that we missed the most effective tool that everyone agrees is the most effective tool. The U.S.
Track, isolate?
Yes.
Yeah.
Yes, test, track, isolate is no one, I've seen no one arguing that isn't the most effective, cost-effective way as well. Just plain effective, cost-effective.
Yes. By any measure, right.
Right. Now, the places that did that also did extremely disruptive shutdowns as well. And so there is some degree of shutdown that has to go with that ability.
Particularly with regard to travel, yeah.
Large-scale testing. Because otherwise your testing, you can't keep up with you can't target the testing effectively if there's too much social interaction, too many large gatherings, right? You find one infected person and they went to a concert with 1,000 people. Oh my God, I got to trace 1,000 people. So if I can limit the size, I can improve my tracking when I do the testing, right? So there is a synergy between the two. But some of these places are already starting to relax restrictions. So their ability to recover other aspects of societal function may be better. I mean, we're early in that, so it's hard to tell because they have to deal with the possibility of new flare-ups. So we have that as a benchmark. You're posing the question of what do we do when we've screwed it up already?
Correct.
Right? Now we've screwed it up. And I'm like, well, maybe we shouldn't screw it up this much anymore, but we're still screwing it up on this. Well, the answer is you just bloody screwed it up. And so now what do we do? We're dealing with our third. It's like putting the minor league team in for the major league for the World Series, right? Because we lost track of the starters and they're on a bus somewhere. We don't know where they are. So the only people we can play are the minor leaguers, and it's a bloody World Series, people. You threw away your best stuff. So I come into this saying, wait a minute, first you have to reframe the argument and saying, what do we do when we've already messed up? Mm-hmm. And part of the mess up is that you're in this situation. It's an exact illustration of how if you blow it early, if you react late, you end up with harder decisions, bigger dilemmas, higher cost trade-offs, less effective action. This is why we come back and say anticipate matters. The ability to anticipate and adjust, to be able to anticipate, see what's really happening in the key discrimination vectors, right? And then be able to adjust to drop what isn't effective and maximize on what's making a difference. That's always the recipe for success. Now we're sitting here going, well, we don't really know. We can't really discriminate. All we can do is brute force kinds of things. And the answer is they're costly, and I'm not sure how effective they are. Well, of course, that's where you are, because you've screwed up.
So, David, but okay, we are where we are, right? it doesn't marginalize any of the decisions that have to be made going forward, right, by public officials or others, right, who in some places have had to put in these brute force kind of restrictions, right, as an attempt to reduce these transmission rates. In some places, those brute force restrictions are not fully yet in place. And as you mentioned, in some places, they're already starting to relax them, right, because of second guessing about their effectiveness or whatnot. Are there not potentially some insights in terms of how one could move out of these brute force kind of restrictions, right? So that is to say, in a place, notionally, let's just say California, right? Because that's where I am right now, and we have these shelter in place restrictions imposed by the county, imposed by the state. And knowing that testing is still a constraint, right, is still limited, right? Are there not potentially some things that one could do to think about how we come out of this brute force restriction in an intelligent way, rather than just saying, okay, everyone can now go about their business again, maybe doing it in a localized way, in a rolling kind of way, and maybe the different levels of policies that one can consider might be a function of the number of test kits, right? It seems as though there's an operations research problem in here somewhere that says, given this population, given this many tests, given some other features, right? What is the extent to which one can safely relax some of these restrictions? How would you implement them? Where would you implement them? Right? That would maybe bring us back to that would relieve some of this economic stress and other, but in a manner that really does mitigate against these potential flare-ups. And maybe there's learning to be had even in that helps us to understand how we maybe avoid getting into this situation in the first place next time.
Those sound like all the right questions to me at this stage.
So that has been the discussion I've had with many people today. You're right, it's the hot topic. It seems to me back to one point I brought up is the point Tom made about things that have become kind of hard to reverse. And given that we are all stakeholders and actors, we're not just affected by it, but we're also actors. Our behavior affects transmission, it affects connection to the high-risk populations. That the nature of the threat, the diversity of perceptions of the threat, the form of risk communication going on, which is highly alarmist, trying to emphasize the worst case. That's what you've talked about, Tom, that again, some people I've been talking to have been saying, your point really is, trying to focus it, is risk communication has been terrible.
Correct.
Because only by trying to scare everybody are we trying to get behavioral change. And there's other mechanisms. And the talk next Monday from one of the leading people in Israel with me in the Resilience Engineering Association webinar, she's emphasizing, they just had a meeting on this with 1,000 people participating across Israel today, talking about the ways that they can build solidarity in the community and get away from this overly negative risk communication as the only strategy for synchronizing human behavior across all the layers of society as we steer through this crisis. So I think there'll be some very interesting things from her. She has a lot of experience in emergency medicine and disaster response. So a little plug for next week. Well, partly because I think I'm going to learn something too in all this. So that's one thing, is changing the risk communication and solidarity to say, what kinds of behaviors do we really need people to do? Whether that's breaking transmission or even if it's relaxing the rules. The second thing is, how do you do any of this in a coordinated, sensible way across the layers of society and the different aspects of society? Once there's this degree of risk out there and the diversity of roles, diversity of economic and other impact, it's very difficult to say we're going to restore things. And what is it we're restoring? Those are some of the political, financial debates in the economic package being debated, or the economic moves being made in other countries. Which ones would have some impact? If you don't help the gig economy, the workers in the gig economy, in terms of sick leave, in terms of guaranteed pay, in terms of some other things, how does that help in terms of affecting transmission, and how can that relate back to opening up for small gatherings,
Yep.
Certain kinds of venues? If you have, the implication, again, being sensitive to early cues while still being tentative and open to re-steer. That's why the steering metaphor is so important in this. We know that if this penetrates into high concentrations of elderly people, death rates go up. Mm-hmm. So how do you actually have effective isolation, but you still have to have interchange? There still has to be some form of social contact, or people get depressed and other problems arise. There has to be some supplies going in and out. There has to be, interchanges with some people and caregivers and others, depending on where the elderly population is located and their capabilities. So how do you do that? Notice how, as we push this thing away from what were the early, more effective strategies, we're getting into harder and harder things to figure out what to do. And the potential for missteps. It was a good intention to do this, but it was implemented in a way that fell apart quickly. And so what we're seeing is the ways that we end up with more harm, more excessive harm, when these things can be recalculated afterwards, because as we get deeper into a series of dilemmas that get harder and harder to resolve when we're in the middle of the dilemma, which is what the whole anticipatory window is about. And you're going to say, and you should say, but we're past that point. We're living in this. We're part of this. You're not an analyst outside it. You're in the middle of it. So what the hell do we do now?
I think we should reconvene on Wednesday. We've moved past some of the topics that we had last week, and I think in a very constructive way. I'd like to keep our conversation going, but I think that what Dave Alderson is working on, what you've been talking about, Dave Woods, is something that needs a little bit of time to gel. How does that sound?
Yeah, and I think we're going to try to dig into a little more about how do we rebalance, what does it look like in this situation to be highly responsive on possible treatments with the effective cross-checks and side effect checks, so that we develop something that's truly effective and minimize the potential for unnecessary harmful side effects at multiple levels in this process. And so we'll hopefully have a little bit of analysis of what some of the parameters of that's going on in the places trying to develop treatments.
That sounds fantastic.